Great. So we've got an exciting session 2 now starting. Thank you very much, Tim, for chairing the first session. So on this session, we will be talking about registries, both from a medical and consumer perspective. Here's some exciting stuff from some of our sponsors, and have a bit of a Q&A there. So there'll be a lot of exciting opportunities to interact with the speakers. So I'm going to be talking first. I'll just give a brief introduction to myself before I start my talk. So I'm the head of the Australian Ocular Melanoma Alliance, which is perhaps most relevant to why I'm here. I am a medical oncologist by training, who has an interest in uveal melanoma. I work at St Vincent's Hospital in Sydney, and obviously see a lot of ocular melanoma patients, working in close collaboration with my ophthalmological and radiation oncology colleagues. So the talk that I'll be giving today is about an update in uveal melanoma registries. So I'm just going to share my PowerPoint and put that onto presenter mode. Hopefully everyone can see that now. So the uveal melanoma registries are a very important piece of the uveal melanoma puzzle. I do actually apologize for my hoarse voice and occasionally my need to cough, because I'm just recovering from COVID. I'm not infectious over Zoom, so don't worry. So if I do burst out into a coughing fit, as I have recently, just that's the reason. So why are uveal melanoma registries so important? Oh, these are my disclosures, and then I don't accept any money from pharma, and I'm very excited about ocular melanoma. So this is a slide that I stole from Dr. Carvajal at some point, but it's proven to be very useful. There's lots of things we know, lots of things we don't know in uveal melanoma, and we're not going to know all of them. So we have to do our best to fill in the gaps of knowledge in the field. Now, sometimes we can fill in the gaps by doing a randomized controlled trial. Sometimes we can fill in the gaps by asking people questions, and sometimes we can fill in the gaps by undertaking a registry. So a registry seeks to understand the patient journey at different levels, and understand the impact of treatments on their physical health, mental health, et cetera, and we can then, once we have all that information, fill in some of these gaps that where we don't know things. So what happens to people who get primary therapy? How bad does their vision become in reality? What risk factors do they have for uveal melanoma? Because we're not very good at asking people about that when a patient turns up into our office. And when we give them a drug, for example, and they've got advanced disease, how well does it actually work? Not what does the trial say, but in the real world, where we're dealing with real people, how well does the drug actually work? And what does that say about whether you should give it to the next patient? There's lots of things that we need to know, and let alone the quality of life issues that we don't have the answers to. And registries are an important way of filling in those gaps. So today I'm going to tell you about 3 registries, which, to my knowledge, are probably the 3 largest registries. Not to say that there aren't other registries, but these are the ones which are generally available to Australians in one form or another, Australian patients and Australian doctors. So they're overlapping to some extent, but they're all around. So the first one is the Vision Registry. So this is run by the Melanoma Research Foundation through the CureOM, and came about partly, for those of you that know Sarah Selig, who talked at this summit last year. Sarah is a Harvard-based physician whose husband, Greg, got ocular melanoma and ultimately, I understand, passed away from it. And Sarah has subsequently, even though it's not her medical profession, dedicated her life to improving the outcomes for patients with ocular melanoma. And one of the initiatives that they've undertaken is this Vision registry, which is a registry where it's patient focused. So it's not the doctors entering the information, it's the patients entering the information. So it has these aims as outlined: to record global cases, to advance understanding and increase collaboration. And it's basically a web interface which you can log into as a patient, and you can put your information in. So this is what it looks like. You put your information into the website, and you get a password. This is all approved by a relevant ethics committee that has said this is appropriate to do. This is not just some people doing it off their own bat, all very formal. And when you register, this is what the landing page looks like. You have your documents and forms, some of the statistics you can see. We'll go through some of those. There's a clinical trial connector there for predominantly US-based. And then there's other surveys and things for you to do. So it's an important way to contribute information to the global effort from a patient point of view. And here's some of the surveys that you fill in when you register. You don't have to do them all at once, obviously, and it'll help the registry gather the information about the patients. So this is some of the data that came out last year from their report. So they've got 421 patients on, 236 completed. Most people want to be known and informed about the research efforts and like to be informed about clinical trials. These are the patients' demographics. You can see that most patients are 60 to 69, mostly in the US. We've got a small Australian contingent here, which is nice to see, of patients that have contributed to the effort. And then you can see the ethnicity, mostly white, which probably aligns with the epidemiology of the disease, and for some reason, mostly female. No, that was slide went backwards. Why is it going backwards? So this is the diagnosis. So mostly uveal melanoma, classically, a couple in the iris, which is a slightly different disease. And then you can see here when the diagnosis was made. And then this is what Melody was talking about, some of the financial considerations. Did the patient face financial considerations that made it difficult to receive medical care, and how did this vary by location of residence? So fortunately, most patients said no, but 20% of patients roughly said yes, and some of these were in the US predominantly. So it really reinforcing the need for patient advocacy. And then here's the patient journey, number of doctors you saw to obtain your diagnosis. So, this is probably needs improvement, to say the least. 3 doctors to 4 doctors to get a diagnosis of uveal melanoma. How far did you travel to receive a diagnosis? So, 50 to 100 miles, it's a fair way to get a diagnosis. So this sort of really reveals the coalface of difficulties that patients face and questions that doctors wouldn't ask. But this is very important for this registry to ask those questions for us to get that sort of information. Then this is some more information about the time of diagnosis and the treatment, support services. Did you get offered support services? So unfortunately, 32% not offered, and 13% said yes. So again, we need to do a better job there. It's very revealing. These are some of the patient priorities. At the time of primary diagnosis, what was your most important thing when making choices about your care? Long-term survival. This is first ranking. Experienced medical team, impact on family. And you can see here that they slightly change if you pull them together. And then questions about surveillance of the other eye as well. And then metastatic disease, where was the metastasis? If you did get metastatic disease, where was it first diagnosed? Mostly in the liver, which is not surprising. And then what treatment did you have? So this really gives us an idea of what's happening in the real world with this data. And then you can search for clinical trials through your portal. And then this is just a shout out to the organization. And you can certainly, as patients get involved and register on the registry, we have put this registry through ethical approval at St. Vincent's in Sydney, such that we are allowed to promoted within the walls of the hospital and increasingly, hopefully, in other hospitals. But you don't have to be told about it through a nurse at St. Vincent's. You can go and get on it yourself as a patient. So it is a very important contribution to the field and to what we understand about the patient journey. Now, there's two medical databases. The first one is the Fight Tumor Blindness, which is spearheaded by Rod O'Day, predominantly out of Melbourne. So this is a registry which has got a greater emphasis on vision and visual outcomes. So the paper describing this has just been published, led by the ophthalmology team, as outlined here. So the ophthalmology team is obviously very interested in visual issues with regards to the plaque that may need to be put on, external beam, the relevance of enucleation or other treatments such as laser. And the registry seeks to understand the incidence and characteristics of the patients and the tumors, to track the primary treatment, and to track the development of metastatic disease. It's got a fairly transparent and intuitive interface where you put the patient's details in and put their HLA status in, their germline status, and then you can put all the characteristics of their tumor in, and then what type of treatment they received. And then ultimately you get this end result where it tells you, for example, for this patient, they had this type of tumor, this size, they received this treatment, they then got some complication that required them to get some anti-VEGF treatment to improve their vision after their plaque, and you can track the patient through that. So that registry is critically important, and again, as I said, probably has a slightly greater emphasis on vision than the patient journey. It tracks both. Then there is the Omni registry, which is run by, at an executive level, myself, Dr. Carvajal, and Dr. Sacco, with the involvement of the company Pulse InfoFrame that run it on the global platform. So this registry was launched in March 2020 and collects more than 360 data elements surrounding a patient's journey. This is initially launched in 11 sites and is now expanding to other sites as best we can. It's registered on clinicaltrials.gov and is seeking to characterize, compare, and contrast some of the management practices in uveal melanoma from around the world to facilitate new insights, benchmark activities, and provide real-world data, which may help with drug approvals. Because for those of you that don't know, these days, drug agencies that approve drugs such as the TGA in Australia or the FDA do require some evidence that actually whatever drug you're proposing to use can actually work in the real world, and it's not just being developed in a bubble. So this registry is done on a secure back-end platform that complies with FDA guidance about the quality of data that you need to submit. So it collects these sorts of characteristics that track the patient's journey, and then it is run on a hub and spoke model. So the Australian hub is run through Mass Clinical Trials Office in Melbourne that runs Australian sites and New Zealand sites. There's a North American hub and a UK hub. And you can see some of the clinical trial sites here that have contributed patients. And I'll show you some of the Australian data in a minute. This is sort of the workflow where all the medical terms are mapped to a standardized medical terminology called OMOP. You can't just say big tumor, small tumor. You have to sort of talk about exactly what the type of tumor is in relation to the standard medical nomenclature. And it is compliant with all guidance about the privacy of data that is entered. So it can't be tracked back to an individual. It's all anonymized, as you can see through multiple verification methods. So there's 985 global patients on this at the moment. Australia has contributed a lot. Just to give you an overview, these are the age, the patients in the overall group, the diagnosis stage, mostly stage 2, and lot of the patients, most of the patients are under surveillance. The management of primary disease to date has been in the patients entered, mostly radiotherapy. A lot of them have had liver-directed therapies, and the first-line drug therapy in those who've received it has mostly been clinical trials where relevant in the patients that have needed it. A lot of the Australian information has come from mostly an ophthalmology practice where the patients are being monitored. So those patients have been mostly, hopefully, cured. So the patients who are needing drug therapy for metastatic disease are mostly relatively low. I think at my site, we've entered close to 40 patients who have had metastatic disease, but there are several hundred patients who have been entered, mostly from a couple of the ophthalmology practices around the country that are being monitored. And you can see here that as of at least February this year, in terms of the global contributions, that whilst North America is leading, we're certainly in Australia making a significant effort. And in terms of the numbers of patients we're contributing to this, and you can see the different types of treatments that patients are receiving in the first line and the other types of all therapies in the first line and second line all put together. And we can use this data to benchmark against other trials. So here's a trial that Dr. Carvajal did at one stage where he said, I think there's a drug which he didn't mention, but might prevent metastases. So they gave it to some patients after their eye removed, and they said, well, we don't know if this works, but let's compare it to what we know about other patients who have had their eyes removed. And at that stage, given the data in the registry, it did not appear that this drug was super effective, although it may be more effective when combined with darovasertib, but as a single drug, it didn't have the requisite effect that would lead us to push this drug forward. But that was because we had the information in the registry and we could benchmark it against it. So that was very helpful. So where's this registry going? The Omni registry, certainly adding data from additional sources, adding more sites, and perhaps adding some patient-related information to the clinical portion of the registry, which is another ongoing effort. So that's the state of play about registries globally. And I won't stop for questions, but I will now introduce Kelli. So we're very honoured to have Kelli Saunders with us. So Kelli is one of our consumer advocates who was diagnosed in February 2020 with a choroidal melanoma in her right eye, and her medical journey took her across state lines with specialist consultations in Adelaide and brachytherapy procedures in Melbourne, all while living near Wentworth in the far southwest corner of New South Wales. Amidst all the challenges, the onset of COVID in March 2020, Kelli navigated her diagnosis and treatment largely alone, braving numerous appointments and procedures with only limited support from the medical profession. And we're very honoured to have her today to share her story with us. And thank you very much for taking the time, Kelli.
No worries. Hello, my name is Kelli Saunders, and I'm here to speak about my journey with choroidal melanoma. As a young child, I was blonde-haired, green-eyed and fair-skinned, and that loved the outdoor lifestyle and got sunburnt on many occasions. I had heard of melanoma as I had one removed on the left side of my face in December 2018, but I had never heard of ocular melanoma. Just a little bit about myself and my family in 2020. Majority of the time I lived on my own on a 330-acre property, 28 kilometres out of Wentworth. I worked at the local nursing home. David works as a contract farmer at Lake Lorraine, 110 kilometres away in Victoria. We have 2 children that attend Yanko Agricultural Boarding School near Leeton in New South Wales, which is 500 kilometres from home. Where is Wentworth? Wentworth is the most southwestern town in New South Wales, where the 2 largest rivers meet, the Darling and the Murray. My home is an hour from my closest optometrist in Mildura, Victoria, a 400-kilometre one-way to my closest ophthalmologist, scans and ocularists in Adelaide, South Australia, and 600 kilometres one way for brachytherapy in Melbourne, Victoria. many kilometres travelled for my survival. This is a very compressed description of my journey. I went for my annual eye checkup in March 2019 in Mildura. Everything was good. I first noticed changes in my sight, such as floaters and darkened areas in August 2019, which I put down to ageing as I'd had my annual eye check in March. Many of my friends were saying they started wearing glasses for reading. Thought I was the same. By December, I just knew I needed to make another appointment. So I booked another appointment in early February 2020 after dropping the kids back at boarding school. During this routine check, he held up his fingers and asked how many. Well, I'm guessing 4, but I can only see 2. That was the start of my journey. Appointments made for February 19th, 2020 in Adelaide to see Dr. James Mukey. James had just been awarded the Australian of the Year, so I knew I was in the best possible hands. James and his team were absolutely beautiful. I went from one room to the next, dilation, photos and consultations, to be told that I had a high possibility of removal, but still may have a chance to keep my eye and have brachytherapy depending on the scans. He sent me for chest x-rays and ultrasounds on the eye and the liver on the Thursday, and then back to see him on the Friday. James informed me that the procedure could be performed, but in Melbourne. The tumour was approximately 11 millimetres by 13 millimetres by 6 millimetres depth, and Melbourne was the only place that had the plaque big enough. It was up to me, brachytherapy or enucleation. David and I discussed our options, and even though it was close to the retina, there still was a 90% success rate, so we chose brachytherapy. Our kids were at boarding school at the time. They knew we were in Adelaide, but not for medical reasons. I had to tell them over the phone that I had cancer, but it could be treated. I couldn't even imagine what they went through. I was trying to stay positive for everyone. A long 6 weeks past my operation date at the Melbourne IDEAYA Hospital was the 5th of April 2020, a day we will never forget, as this was my husband's 50th birthday. During all this, Australia was locked down in COVID-19. This meant kids being homeschooled, lockdown restrictions in place, border passes required, while all dealing with cancer. With the kids and the passes sorted, David and I took off to Melbourne to see Dr. Peter McKenzie and Dr. Rod O'Day, 600 kilometres away. Arriving at the hospital, David came and sat with me while they started prepping for the operation. This is when I was told that the procedure would be done with a local anaesthetic, not a general. That's when the anxiety kicked in. So when it was my turn, I walked into theatre, laid on the bed, and was anxious under the skin, but kept my cool and laid as still as possible. Surprisingly, I came out of the operation feeling well and positive. On day 5, I had the plaque removed, once again awake, but this time, not a nice memory. The 600-kilometre trip home, I wore a patch to help with the nausea from motion. I was glad to arrive home safe and sound with the kids' parents around me again. I returned to work at the nursing home for about 6 weeks after the procedure, but my vision was still not great, so I resigned due to the safety of myself and the residents. I had to rethink my employment and what my new challenges are or going to be. During all this, COVID-19 was still quite prevalent and many restrictions were still in place. I had to take myself alone to all of my follow-up appointments in Adelaide. This meant scans were a 900-kilometre round trip on a Friday, 200 kilometres of that being dirt roads. Then on Tuesday, I had to travel 450 kilometres to the specialist, which meant eye dilations. So I had to stay in the motel room and not allowed out. And then the return trip home the next day. Most things were going along fine. New jobs, scan every 6 months and x-rays overall were good. Over a 2-year period after plaque treatment, I struggled at times physically and emotionally, but learned to live with the blurry vision, floaters, headaches, and feeling tired. But I was determined that I was not going to let this intruder ruin my life. Just after the 2nd anniversary, then I noticed my vision wasn't quite as good. I was due to have my ultrasound. I took myself off to Adelaide for my scans on the Thursday. I informed her that I had noticed changes and that I had lost most of my sight in that eye. After all of the scans were completed, I looked at her and said, "It started to regrow again, hasn't it?" I was not at all shocked when they said they needed more time to check over my results. My own gut feeling was, it's regrowing. I drove home the next day knowing full well that I would likely receive bad news. I had the weekend to sort myself out, be strong for what the outcome may be. David came with me to the appointment, but he couldn't come in as there was still COVID-19 restrictions in the clinic. I got all my checks done. Then James said there had been changes. I said, "Okay, where to from here?" James replied, "You'll need an enucleation." I seem to handle these situations as quite well as it is out of my control. But with all this, he then said, "I'm going to have to refer you to a new ophthalmologist as he was going to retire at the end of June. Could you come back in 10 days so we could start the procedure for the removal with Dr. Sia?" So out to the car I go where David was waiting. He looked at me and asked, "How did you go?" I shook my head and said, "Nah, no good this time. It's grown back." We sat in the car feeling a bit numb. No, my inkling was actually a reality now. I still had some good news that it hadn't metastasized, so that's a positive out of a negative. I was more worried about everyone else, my husband, kids, and family. My next chapter of enucleation begins. On this day 2 years ago, I told my family and friends that the tumour had regrown and that I was going to have a removal. It's something I never want to do again. I met with my son in him to get it all right. I was given the operation date and prepared myself mentally for the outcome, but then the date being changed as Dr. C contracted COVID-19. Monday, the 11th July 2022 was my new operation date. Arriving at the Flinders Hospital, I walked myself in and started the paperwork. I took my last ever photo of myself with two real eyes. Dr. Sia came in and asked, did I have any questions? And I requested photos of my eyes so I can justify why I needed it removed. The last thing I remember saying is, "Let's get this eye out so I can move on." I came out of the surgery well, as one could expect, with two big compression bandages over the right socket. This is real. I no longer have two eyes. My one night stay turned into 4. One thing I did notice was my vision was clearer with just one eye. We travelled the 450 kilometres back home for my recovery and lots of rest, no strenuous lifting, and a long road to readjustment to life without an eye. 2 weeks after surgery, I was back seeing Dr. Sia with great results, that it was healing well and I should get maximum movement. David's work is outstanding. I have maximum movement and had no problems since the surgery. My 8 weeks post-surgery, I went and started the prosthetic journey in Adelaide. 3 appointments later with Peter Knowles, I received my eye. I couldn't have been happier. His work is impeccable. He made me feel whole again, and to see that the eye looks so real, I haven't had any insecurities, and it's been a positive outcome from something so horrible. 6 months post-surgery, I get a call from my friend Corinda, and she has the exact same condition. Only her choice was removal. I said, "Lose an eye, save a life. We will cope." I was so glad I was able to support her, as I didn't know anyone else at all that had gone through the same as what I had gone through. And now we are sight sisters. 2 years post-surgery, I can say I have overcome more than I thought I ever could. Laughter and comedy and determination are my coping mechanisms. I am now 4.5 years since diagnosis and still kicking goals. A huge thank you to everyone that has been part of my journey. I am ever so grateful. Thank you.
you, Merrin, and thank you, Kelly. Kelly, that was an amazing journey, and really taken aback by all the ups and downs and that you went through and how you managed to persevere in the end. We are just doing some background work, and you can think about any questions you want to ask. For now, we're going to shortly be transitioning to a gold sponsor presentation from IDEAYA Biosciences, and which will be and then we'll facilitate it. We'll have a question and answer with IDEAYA. So I will now get the video started from IDEAYA, and then after that we have Darrin, Dr. Darrin Beaupre with us to answer questions from me, and we'll take it from there. But firstly, we'll get the video going.
First, I'd like to thank the organizers for inviting me to speak with you today. My name is Darrin Beaupre. I'm the Chief Medical Officer at IDEAYA Biosciences. And what I'll be discussing with you over the next few moments is giving you a brief overview of IDEAYA itself, and then focusing in on our lead program called darovasertib. So IDEAYA Biosciences is a company focused on precision medicine and capitalizing on synthetic lethal approaches for cancer therapy. Therefore, we target tumors based on their genetic backgrounds, or we utilize combination therapy approaches to preserve vital pathways associated with cancer growth and survival. And as shown here, our pipeline is broad. We have programs across all phases of development. And we have key partnerships that allow us to not only address rare tumors, but tumors very common within the population. And our lead program is darovasertib, which has now has reached late phase development. And I'd like to spend a few moments talking to you about sort of the background, which is the disease uveal melanoma. Now, uveal melanoma is a disease, most common tumor of the adult eye. And unfortunately, there aren't very many good therapies available for this disease. As you can see on this table, tebentafusp is an approved therapy for HLA-A2 positive patients with metastatic uveal melanoma, and the response rate's anywhere from 5 to 10% with a progression-free survival of about 3 months. The same can be said about the ipi-nivo combination, or pembrolizumab. As a single agent, immunotherapy generally gives a similar overall response rate of 5 to 10% with a progression-free survival of 2 to 3 months. And multiple other therapies or combinations have been trialed, and they really haven't done much better. So suffice it to say, a significant unmet medical need exists for the metastatic uveal melanoma population. Well, this brings us to the biology of the disease. It turns out that in metastatic uveal melanoma, the vast majority of patients have mutations in GNAQ or GNA11, which are proteins that activate protein kinase C signaling. So that's a key driver in the disease, we've learned. But also what we've learned based on preclinical data as well as clinical data, that the MET pathway is also highly relevant in the metastatic setting. So therefore, we set forward to put together the darovasertib crizotinib combination and test it in patients with metastatic uveal melanoma. This is an example of some of the data that we've presented at ESMO in 2023. As an oral presentation, you can see the waterfall plots. The top plot is patients who were treated, who were treatment naive, had received no prior therapies, and you can see the overall response rate with the daro-crizo combination was 45% with a 90% disease control rate. Vast majority of patients experienced tumor shrinkage. Same can be said for even in the relapse setting, shown at the bottom, where the overall response rate was about 30%, with a disease control rate of 89%. Now, this activity is irrespective of their HLA status, unlike tebentafusp. Here, you can see both in HLA-A2 positives and negatives, a high overall response rate and a high disease control rate. And in addition, if you compare the daro-crizo combination with respect to progression-free survival to tebentafusp in its registration trial, the two curves are shown here. The control arm was standard immunotherapy versus TEBI. You can see the median progression-free survival was 2 to 3 months, as opposed to the Darrow-Crizo combination, where it's at least double that amount. You can see at the tail end of that, at 2 years, 20% of patients on the Darrow-Crizo combination seem to be continuing to receive benefit. So the Darrow-Crizo combination, we believe, is a significant advance in the metastatic uveal melanoma setting, and we're pursuing further testing of this combination in a randomized trial. We're equally excited about the opportunity for darovasertib in the neoadjuvant setting, and this is based on some data that was presented by Anthony Joshua at ASCO this year as an oral presentation, testing darovasertib in the neoadjuvant setting, that is for patients with uveal melanoma that's localized to the eye, to determine whether shrinking the tumor could result in preservation of the eye. In other words, converting a patient from assured enucleation to perhaps a transition to something like plaque brachytherapy or proton beam therapy. And you can see here, similar to what we saw in the metastatic setting, when you apply darovasertib to patients who have uveal melanoma localized to the eye, not only do the vast majority of patients have tumor shrinkage, but up to 2/3 to 3/4 of patients went from almost a certain enucleation to being able to be converted to a less invasive procedure. So a significant advance in the field. And based on this data, we really believe that darovasertib, either as a single agent or in combination with crizotinib, can have a significant impact on the entire patient journey for patients with uveal melanoma, as shown here. We have plans to address this disease both in the metastatic setting, as you can see with the Darrow-Crizo combination, both in HLA-A2 positive patients in a single-arm phase 2, or in HLA-A2 negative patients in a randomized phase 3, but also in the neoadjuvant setting, both in our single-arm phase 2 trial and our randomized phase 3 trial that's planned to allow full approval for darovasertib in the neoadjuvant setting, to continue to build on the data that was presented by our Australian colleagues. But in addition, what we hope to do is allow prevention of metastases altogether with the Darrow-Crizo combination. So an adjuvant trial is also planned. And amongst all of these studies, we hope to be able to bring a significant clinical impact to patients with uveal melanoma that's very much in line with the company's vision of precision medicine and using novel combinations to have large impacts on patients' tumors. So thank you very much for allowing me to speak to you today. Again, I thank you for the opportunity.
Thank you very much, Darrin. Recorded Darrin, now to real Darrin.
Right.
So we just got the opportunity to, I think, just a short question, if I can, Darrin. It's obviously very exciting data, and it's great opportunity for uveal melanoma patients. What are some of the key steps your organization needs to take to get this exciting agent to patients soon?
Yeah, thanks for asking, Anthony. We're absolutely thrilled about the progress that we think we're making in the field. As Rich pointed out earlier, about the enthusiasm there is, it's obviously palpable among investigators like you and all the folks that we work with. Several things that we have to tackle, though. This is exciting times, but a number of things need to be worked out. First of all, we have to make sure that our registration phase 3 trial continues to enroll rapidly, and I'm very, very happy to tell you that we're actually enrolling ahead of schedule, so that's going extremely well. And then we're at the precipice of getting ready to have a discussion with the FDA about our neoadjuvant approach. As Rich showed earlier in the group of presentations, we have a single-arm phase 2 trial that's running with 2 patient populations. One is similar to what you studied in your investigator-sponsored trial, those who require enucleation, but also patients who require plaque brachytherapy. And the idea here is to not only prevent enucleation, but obviously, reduce the amount of radiation, preserve vision, et cetera. But, with this approach, a number of questions still, remain to be answered. For example, up until recently, there hasn't been a need to have a response criteria for localized uveal melanoma because there wasn't really any therapies around that were shrinking tumors. Well, that's not true anymore. In fact, we have a therapy that you showed, obviously, that does it very well. And now we have to actually come up with a response criteria. So we're working with a number of experts, not only in this call, but with the COOG group, the Clinical Ocular Oncology group, to help define response criteria for localized uveal melanoma. But in addition, things that we have to lay out and characterize is what a response looks like, how much tumor shrinkage, what's progressive disease, et cetera. Also, very, very important things like, how much radiation reduction is clinically relevant, vision, how are we going to measure vision? Are there vision prognostication tools? You utilized one in your presentation that we think is very useful. It allows us to get information about vision relatively rapidly, as opposed to waiting the years it might take to get some of those answers. And again, talking to the FDA, we want to talk to them about not only how do we get that trial, moving through accelerated approval, but then what does a full approval randomized phase 3 trial look like? So that's sort of some of our immediate questions that we need to sort out. But these are good problems to have, obviously. So we're in a position where we're doing very, very good things, but there are a number of scientific questions come up with that. And the only last thing I would mention is we still haven't forgotten about the adjuvant setting. It's great to save the eye. It's great to save the vision. It's great to reduce the radiation toxicity, but we also want to save lives. And that's where I think the adjuvant study comes in. And there, once again, we have plans to talk to the FDA, but questions arise even in that area. How long do you treat? Who do you treat? Is it just the high-risk patients? What about intermediate risk patients? How long should therapy be? Long and short of it is we have so many more questions to answer, but the good news is we have some tools now that can actually help us through this and actually help patients at the same time. So just to finish, I'd say exciting times. We're looking forward to working with people on this call, people involved with uveal melanoma, because it's with your help we're going to be able to find the answers. And it's really, really exciting times for the patients. And so IDEAYA Biosciences is pushing hard to get these studies rolling as fast as we can.
Great. It's very exciting times. And Darrin, thank you for your personal efforts, as well as IDEAYA Biosciences as being one of the sponsors of the meeting. It's very much appreciated. There have been a couple of questions for Kelli just before we wrap up and go to the break. Kelli, there's a couple of people who wanted to know, where did you get support from? I guess if you were working across state lines, obviously there's not much support for you locally where you lived. Did you link up with Facebook groups? Was there any other local resources you could tap into? Was there help at all?
Initially, no. I did it alone or with family and friends. I had great support there. When it came to the enucleation process, I found the Omni website, Facebook site that Susan Vines has established, and that was great support. I found a lady in Queensland that helped me through that, and we're still friends today. So, yeah, it's been really good. We've been supporting each other. But as of when I went and got the enucleation, they couldn't offer me any support. There was no nurses at the time because of COVID, and the lady in Sydney wasn't available. So pretty well did it on my own with family and friends.
Wow. That's quite a journey. So we will certainly, if you need any help in the future, please certainly reach out. You're amongst family and friends now on this call, and there's lots of people who are happy to help you if need be. We are, and thank you for your talk as well and sharing your experience. I know it can be quite traumatic to revisit some of those memories, and really appreciate the effort that you made to do that with us today. We are due for break because we have to get back on track with the timing for returning from the break at precisely 11:15 for the session 3. That's 11:15 Australian Eastern Standard Time, so approximately 15 minutes from now. I will just wrap up by saying there is the donations page for ocular melanoma research. The web link is in the chat box, and all the donations go to Melanoma and Skin Cancer Trials Australia, which is the legal underpinning of AOMA. They're the government-endorsed National Melanoma Cooperative Trials Group that run AOMA. And any donation over $2 is tax deductible. So please have a look at the chat group for that web address to make a QR code to make a donation. And now would be a good time to do that before June 30, which is the end of our tax year. So thank you very much, Darrin. Thank you very much, Kelli. I think this is a great session, and look forward to seeing you all back in 15 minutes.